Welcome to the Deep Dive. We sift through complex research to bring you the essential insights. Today we're tackling pneumonia, a disease many think they know, but, well, there's a lot more to it.
There really is, and we have to start with just how serious this is globally. Back in 2015, lower respiratory infections, or LRIs, they were the #1 infectious cause of death worldwide.
#1 infectious cause. That's
And
huge.
5th leading cause of death overall, so it's a major killer.
That really puts it in perspective straight away. We're not just talking about, a bad cold. And the main culprit, bacteria-wise?
Streptococcus pneumonia. It was responsible for about 55% of those LRI deaths. That's roughly 1.5 million people just in that 1 year.
Incredible numbers.
Yeah.
So our deep dive today aims to get past that general idea of a chest infection. We want to look at how it's classified, why diagnosis is so tricky, like the chest x-ray issue, and crucially, the newer strategies for treatment and prevention, especially biomarkers.
Exactly. We need to understand the nuances.
First things first, let's nail down the definition. When does an infection in the lungs actually become pneumonia? Because just having germs there isn't that.
That's spot on. It's a key distinction. Pneumonia specifically means an infection in the lung involving the alveolar space, those tiny air sacs. And critically, there has to be an inflammatory response there.
So inflammation is a trigger word.
It is. If you just have the microbes hanging out in the alveoli without that inflammation, that's just colonization, not pneumonia. The inflammation is what defines the disease.
Got it. Okay, let's talk classification, because you mentioned location matters a lot for treatment.
It really does. The standard grouping system is based on where the patient likely got infected. This points towards different types of bugs and, importantly, different resistance patterns.
So the most common one is community-acquired pneumonia, CAP.
Yep, CAP. Acquired out in the community, outside of healthcare settings. Then there's HAP, hospital-acquired pneumonia. That's when someone gets it after being in the hospital for more than 48 hours. And then there's VAP, ventilator-acquired pneumonia. That's specifically for patients in the ICU who've been on a ventilator for over 48 hours.
And the reason this location distinction is so vital.
It comes down to resistance. Infections picked up in hospitals, or especially ICUs, are just much more likely to involve pathogens that are resistant to common antibiotics.
I think I saw it mentioned in the sources of another category. HCAP, healthcare associated. Is that still used?
Good question. That reflects how guidelines evolve, doesn't it? HTAP was proposed, but it never really got full international buy-in, and honestly, the latest evidence doesn't really support keeping it as a separate category.
Okay, so stick to CAP, HAP, VAP.
Exactly. Those are the main ones now.
The other big classification split is based on the person's immune system, immunoconfident versus immunocompromised. For you listening, how does this change things?
It changes things dramatically. The more compromised someone's immune system is, maybe from HIV, cancer treatment, an organ transplant, certain drugs, the wider the range of potential germs becomes. You start seeing unusual suspects.
Right.
But maybe even more importantly, the symptoms can change. Think about it. Classic signs like fever or a bad cough often rely on a strong immune response fighting back.
So if that response is weak.
Exactly. The symptoms might be really subtle or maybe even absent altogether. This makes diagnosis incredibly difficult in immunocompromised patients. You need a high index of suspicion.
Okay, let's shift to how the infection actually starts. We might imagine this big invasion, but often it's more subtle, right? Like microaspiration.
Yes, that's the most common route. People inhale tiny amounts of material, including bacteria from their upper airways, down into the lower lungs. We need to remember the lungs aren't sterile normally.
Right, they have their own little ecosystem.
They do. A normal microbiome with bacteria like Streptococcus species. Usually our lung defenses keep them in check. Microaspiration happens all the time, especially during sleep, but defenses usually clear it up.
But sometimes those defenses get weakened. I know viral infections often play a role.
Absolutely. Having a viral infection first, like the flu or even a bad cold, can really mess up the lungs environment. It can damage the airway lining, disrupt that normal microbiome.
And basically open the door for bacteria to move in and cause trouble.
Precisely. It paves the way for a secondary bacterial pneumonia.
Now, thinking about risk factors for you, the listener, we know the obvious ones: age over 65, chronic lung disease like COPD, diabetes, cancer. But what about lifestyle factors or even medications that might be surprising?
The lifestyle links are quite stark. Smoking, for instance. Current smokers have more than double the risk of getting community-acquired pneumonia compared to non-smokers.
Double. Wow.
And alcohol intake. High chronic alcohol use is linked to an 83% increased risk of CAP. And it seems to be dose dependent. The risk goes up about 8% for every extra, say, glass of wine or beer per day, roughly speaking.
That's significant. And it's not just lifestyle choices, right? Some common medications that aren't immunosuppressants are also implicated.
Yes, and this is often a blind spot. The sources specifically call out proton pump inhibitors, PPIs, used for acid reflux, and also antipsychotic medications.
Things that people might take daily without thinking about lung risk.
Exactly. They might increase aspiration risk or subtly affect defenses. So it's not always the obvious things that increase your susceptibility.
Okay, so given these varied risk factors and the fact that symptoms can be misleading, how do doctors actually confirm it is pneumonia? Sounds tough.
It is a real diagnostic challenge. Ideally, a definitive diagnosis needs 4 things to line up. 1, the patient's signs and symptoms. 2, radiological evidence, like changes on an X-ray or CT.
Okay.
3, identifying the actual pathogen causing it. And 4, seeing a clinical course and response to treatment that fits with pneumonia.
But getting all 4 sounds difficult. The sources mentioned that even in the ER, maybe up to a quarter of initial pneumonia diagnoses end up being something else entirely by discharge.
That highlights the uncertainty. And a big part of that starts with the imaging, specifically the chest X-ray, the CXR. For years, it was the go-to tool. But compared to modern CT scans, it's surprisingly unreliable.
How unreliable? Like, does it miss things?
It does both. It leads to overdiagnosis and underdiagnosis. One study found that when you compared CXR results to CT scans, up to a third of patients diagnosed with pneumonia based only on the X-ray actually had no infiltrate, no sign of it on their CT scan.
A third. That's huge.
It is, which is why there's more talk now about using CT or even lung ultrasound, although we're still figuring out exactly how they best fit into the management pathway.
So imaging is tricky. What about the clinical picture? Most people think cough, maybe shortness of breath.
Yeah, cough is common, maybe 75% of cases. Difficulty breathing, dyspnea, around 65%. Systemic things too, like fever, chills. But confusion is really common, especially in older or sicker patients.
Right, confusion.
And here's a critical point. About 10% of people with CIP, community-acquired pneumonia, show up with only extrapulmonary features.
Meaning symptoms outside the lungs.
Exactly. They might come in because of unexplained falls or sudden weakness or even acute abdominal pain, nothing obviously pointing to their chest.
Wow. So you really need to think broadly?
You do. High index of suspicion is key.
Okay, so imaging is imperfect, symptoms can be misleading. Surely microbiology finding the bug is the key, but that seems to be a bottleneck too.
Oh, absolutely. Even with all our modern molecular tests like PCR, we only identify a specific pathogen in maybe 50 to 75% of CIP cases.
Which still leaves a big chunk unknown.
It does, but wait, it gets worse. If you look at just routine, standard, culture-based methods, the kind done in most hospitals day to day,
Yeah.
the identification rate plummets. We're talking maybe 5 to 10% of cases where they actually grow the specific bacteria from standard samples like sputum or blood.
Only 5 to 10%. That seems incredibly low. Why is it so hard with standard cultures?
Well, several reasons. Getting a good quality sputum sample, one that's actually from the lower airways and not just saliva, is difficult. Blood cultures often aren't positive unless the infection is very severe.
Okay.
Plus, timing is everything. Often, patients have already started antibiotics before or right as the samples are collected, which can stop the bacteria from growing in the lab. And cultures just take time days, usually.
Right. So you can't wait for that result to start treatment.
You absolutely can't. And this huge diagnostic uncertainty is exactly why treatment almost always starts empirically, meaning doctors choose broad-spectrum antibiotics based on the likely suspects before they know the exact cause.
Which leads us neatly into treatment strategies. If finding the specific bug is slow, or often fails, we need faster ways to guide therapy, right? Like figuring out if it's bacterial versus viral.
Precisely. And this is where host-response biomarkers have become so important. They offer a way to get clues quickly, bypassing the slow microbiology.
How do they work?
They measure the body's own reaction to the infection. The 2 main ones studied for pneumonia are C-reactive protein, CRP, and procalcitonin, PCT.
Okay, CRP and PCT. Is one better than the other?
Well, PCT seems to have an edge, particularly for guiding antibiotic decisions. Its levels go up and down much more quickly in response to the actual bacterial load compared to CRP. It's more dynamic.
So it gives a faster, more real-time picture.
Kind of, yeah. And we have good data now. A large meta-analysis looked at using PCT levels to guide antibiotic therapy. It showed that PCT-guided strategies led to less antibiotic exposure. Patients got antibiotics for about 5 days on average versus 7 days in the control groups.
Shorter duration, that's good. Any impact on outcomes?
Yes, importantly, there was also a small but statistically significant reduction in 30-day mortality. It dropped from 10% in the standard care groups to 8.6% in the PCT-guided groups.
So potentially fewer side effects from antibiotics, less resistance pressure, and slightly better survival. Seems like a win-win.
It's definitely a promising strategy for optimizing antibiotic use.
Now, speaking of timing, getting treatment started fast is crucial, especially if someone is really sick.
Absolutely critical. If severe sepsis is suspected along with pneumonia, guidelines recommend starting appropriate antibiotics within 1 hour of recognition. The clock is ticking.
But that's for bacterial infections. What about viruses like the flu?
Good point. For influenza, antiviral treatment, things like neuraminidase inhibitors, works best if started very early, ideally within 48 hours of symptoms starting. The viral load peaks quickly, so you need to hit it fast.
So that initial uncertainty really dictates the strategy. Start smart, then focuses. Begin with broad coverage because you don't know the exact cause, but then use incoming data like those biomarkers, cultures, if they become positive, how the patient is doing to narrow down the antibiotics as quickly as possible.
That's the mantra. Start broad, but de-escalate or stop antibiotics promptly based on more information.
Are there other treatments used alongside antibiotics? Adjuvant therapies?
Yes, there's ongoing discussion about things like systemic corticosteroids. Some evidence suggests they might offer a small mortality benefit, but only really in patients with very severe pneumonia. They aren't routine for everyone.
Okay.
And certain antibiotics, like macrolides, azithromycin is a common one, seem to do more than just kill bacteria.
Yeah.
They also have immunomodulatory effects, meaning they can help calm down excessive inflammation.
Ah, interesting. So that might be another reason they're sometimes chosen early on.
It's part of the calculation, yes. And this whole focus on targeted, appropriate therapy is also why we're moving away from routine long courses. Instead of defaulting to 7 or 10 days of antibiotics, we're seeing shorter 5-day courses, or courses guided by those PCT levels, becoming more common.
Right. Let's zoom out again to the bigger picture. Epidemiology. We touched on age earlier. The risk really climbs steeply.
It's dramatic. For adults under 65, the annual rate of hospitalization for pneumonia is maybe around 6 to 8 per 10,000 people. But once you get to 85 years and older, it jumps to somewhere between 160 and 224 per 10,000.
A huge leap. And globally, there was that surprising trend in mortality you mentioned earlier.
Yes, this was striking. Between 2005 and 2015, deaths from lower respiratory infections actually decreased in countries with low to middle sociodemographic index, or SDI.
Okay, so less developed regions saw improvement.
Right. But in high SDI countries, the most developed nations' LRTI mortality increased by nearly 10% during that same time period.
Increased. Why would that happen in countries with more resources?
It's complex, but likely reflects factors like aging populations, maybe higher rates of antibiotic resistance, making infections harder to treat, and potentially different circulating pathogens. It shows that just having wealth and infrastructure isn't a magic bullet against this.
That is counterintuitive. Prevention is obviously key then. Vaccines have made a difference, particularly the pneumococcal ones for kids.
Oh, absolutely. The pneumococcal conjugate vaccines, PCVs, given to children have been a major public health success story. They don't just protect the kids who get them.
They create herd protection.
Exactly. By reducing the amount of vaccine-type bacteria circulating in kids who are major carriers, it indirectly protects unvaccinated adults too. We saw significant drops in adult pneumococcal pneumonia after PCVs were introduced for children.
But there's a challenge there too, right? Something called replacement disease.
Yes, that's the ongoing battle. When you suppress the bacterial types covered by the vaccine, other types, non-vaccine serotypes, can emerge and fill that gap.
So the bacteria essentially evolve around the vaccine.
In a way, yes. It means we constantly need to monitor which serotypes are causing disease and potentially update the vaccines to keep up. It's an evolutionary arms race.
Finally, let's talk about what happens after someone survives pneumonia and leaves the hospital. What's the long shadow of this illness? Is recovery quick?
Unfortunately, no. Recovery is often slow and incomplete for quite a while. Studies show that around 70% of patients still report lingering symptoms like cough, shortness of breath, or fatigue even 4 to 6 weeks after discharge.
70% is a lot.
It is. But perhaps even more concerning are the hidden, longer-term risks, especially to the heart.
The heart? How is that connected?
Pneumonia puts immense stress on the whole body, including the cardiovascular system. Within just 30 days of having community-acquired pneumonia, a staggering 18% of patients experience a major cardiac complication.
18%. What kind of complications?
Things like new or worsening heart failure, heart attacks, acute coronary syndrome, or serious heart rhythm problems, arrhythmias.
That's a huge immediate risk after the infection itself. Does that risk persist long-term?
It seems to. The data on long-term mortality after being hospitalized for CAP is really quite sobering. About 17% of patients die within the first year after hospitalization,
1 in 6.
and it climbs to 40% mortality within 5 years.
40% within 5 years. What are they dying from? Is it recurrent pneumonia?
Often not directly from pneumonia again, but primarily from vascular causes like heart attacks and strokes and other respiratory problems. It suggests the pneumonia episode acts as a major insult that has lasting consequences for overall health.
Okay, so wrapping this up, this deep dive really underscores that pneumonia isn't simple. It's defined by that specific inflammation in the air sacs. The diagnosis is genuinely challenging with unreliable X-rays and slow microbiology.
But biomarkers like procalcitonin are offering a path to smarter, shorter antibiotic use.
Right, but it remains a massive health burden, made worse by resistance and maybe these complex trends we see even in developed countries. And the long-term impact on survivors, especially cardiovascular risk, is significant.
Absolutely. The current reliance on starting broad-spectrum antibiotics empirically, while necessary now due to diagnostic limits, just isn't sustainable long-term.
So looking ahead, what's the big shift needed? What should you, our listeners, watch for in future research?
The real game changer, the frontier we need to push towards, is moving away from this empirical antibiotic-first approach. The focus has to be on developing truly rapid, accurate diagnostics, things that can tell us quickly what pathogen is causing the infection, ideally right at the bedside.
To enable targeted therapy right from the start.
Exactly, but not just targeted antibiotics. The ultimate goal would be diagnostics that enable the immediate use of non-antibiotic pathogen-specific therapies. Imagine things like antitoxins tailored to a specific bacterium or highly specific immune modulators, therapies that could neutralize the threat without needing broad-spectrum antibiotics at all.
That sounds like a paradigm shift.
It would be. That's the kind of innovation that could truly tackle inappropriate antibiotic use and maybe, just maybe, start to bend that curve on the long-term mortality we see after pneumonia. That's the future we need to work towards.